Okay, in this case study, we will examine a patient that my partner and I had recently. So we get dispatched to a chest pains call and we walk in the door. It's a beautiful morning out, about 10 o'clock in the morning, 65, 70 degrees, beautiful blue sky. We're met at the front door by the patient's wife, and the patient's wife says, come on in. So we come in and we find the patient. He is a 66-year-old male, and he's laying supine on the sofa. And he has a mask on. His wife has a mask on because right now we're in the middle of the COVID pandemic. So my partner, who was the first in the door, says, "Hey, good morning, sir. What's going on?" And a gentleman says he has chest pain. Okay, well, what were you doing when it started? And can you describe the chest pain? So he described it. He said it about 20 minutes prior to calling 911. He was out back in the backyard stacking firewood when he developed this, what he describes as retrosternal chest pain that radiates posteriorly towards his thoracic spine. And he also has like an ache in his jaw, his neck, and both shoulders. So at which point we decide to get some vital signs on him and put him on the heart monitor. So I'm getting vital signs. Meanwhile, my partner is putting the electrodes on for the heart monitor so we can take a look at the electrical activity of his heart. And my partner says, "Wow, hey, ma'am, do you have a bath towel or something? Your husband's like really sweaty." So, which means he is. It's about 65 degrees out. There's no reason for him to be sweating. It's not like he just ran, a 10K or something like that. So we call that diaphoresis. So the patient's diaphoretic. His skin's got good skin color, and there are no other clues. So towel him off and start putting him on a heart monitor, and we're asking him some questions. Medical history, his only medical history is hypertension, for which he takes hydrochlorothiazide, aka HCTZ, no pertinent allergies. He's a little short of breath, along with his chest pressure. No nausea, no vomiting, no other somatic complaints. So the rest of his review of systems is negative. And so now we put him on the heart monitor and we get a 12 lead EKG. Okay, so before we talk about the EKG, let's take a look at some of the anatomy of the heart and a little basics about EKGs.
All right, so the heart's got four chambers, two up top, two on the bottom. So the two up top are called the atria, two on the bottom are called the ventricles. And the atria contract at the same time, and the ventricles contract at the same time in sequence. So it goes boom, 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 boom. Atria, ventricles, atria, ventricles, atria, ventricles. So the atria squeeze blood inferiorly down into the ventricles. And while the ventricles are squeezing blood out to their respective regions, the right ventricle pumps blood out to the lungs, and the left ventricle pumps blood out through the aorta to the rest of the body. So while the ventricles are squeezing blood out, the atria are refilling, and it goes like this. Okay? So when we look at the heart, we'll see it's located in the chest, so medially, slightly to the left of the sternum. All right, and it's about the size of the human fist. If you make a fist like this with your thumb up top and you point it, kind of like you're scooping ice cream out. Okay, like really hard ice cream, scooping out like this, sits in your chest. Okay, so atria, ventricles, and when you look at the heart model, you'll see there's a major artery coming out of the heart called the aorta, and right off the aorta there are some smaller blood vessels that feed the actual heart muscle itself with its own blood flow. Because even though there's a ton of blood flowing through the heart muscle itself doesn't get its nutrients from that blood. It has its own separate circulation called the coronary circulation. Okay, so let's take a look at this diagram. So let's start here with the left ventricle, because this is the patient's left, this is the patient's right. So we're going to start with the left ventricle, and it's a very, very muscular chamber, and it pumps blood out through this major artery here called the aorta. It has several branches, three branches up top, and it makes a U-turn and dives down behind the heart and goes inferiorly. So the three branches up top feed your right arm, your head, and your left arm, okay, very generally. And the part of the aorta that dives down behind the heart goes inferiorly, basically feeds the whole inferior aspect of your body. Okay. So now those arteries get smaller and smaller and smaller, they form arterioles, and then they get even smaller. They become capillaries, which are one cell wall thick. Remember, simple squamous cells. And then we do nutrient exchange and gas exchange at the cellular level, and we're offloading oxygen and we're dumping out CO2 back into the bloodstream because we're doing cellular respiration. Okay, so now we have CO2 rich blood coming back up to the heart, and it comes up from inferiorly and from superiorly, and that carbon dioxide rich blood gets dumped into the right atrium, which then pumps down to the right ventricle, which then pumps blood out through the pulmonary artery, out to the pulmonary trunk and pulmonary arteries, out to the lungs. And that's where we get rid of the CO2 and we pick up oxygen via diffusion, right? So now we're coming back from the lungs with oxygen rich blood. That blood ends up dumping into the left atrium, which pumps to the left ventricle. And there we have the whole circuit. Okay. So that's the mechanics behind it. You can think of it as a big plumbing problem with the heart being a four-chambered pump. Okay.
Let's take a look at how to interpret EKGs and actually what is an EKG to begin with.
Okay, so now let's take a look at what we're looking at in an EKG. So we've got all these funny looking squiggles here. Some are rounded, some are spiked, some go up, some go down. So basically, this is what we call the isoelectric line. Okay, it's like a neutral line. Anything above that is positive, anything below that is negative. Okay, the first upward deflection, we call it, the first upward bump, we call that the P wave. And that is electrical activity flowing through the atria, causing both atria to contract. Okay, this is electrical, this is mechanical. They're different, but they're very closely related. Okay, after the atria contract, then we have the ventricles, both the right and the left ventricles contract, and we call that the QRS complex. Q R. Oh, there's already an S there. Okay, so these are the ventricles contracting. And while the ventricles are contracting and pumping blood out, the atria are refilling. And we don't actually see the atria refilling on the cardiogram because the voltage, the amplitude is so low that we really don't see it. Okay, and then this last upward big deflection here is called T wave. And this represents the ventricles repolarizing or recharging. Okay, so you have P, Q, R, S, T, and it repeats on and on and on. Hopefully, it repeats on and on and on. Okay, so this is a really basic rundown. Okay, so what we're looking for here on this particular patient's EKG is we're looking at this region here. It's called the ST segment. We're looking to see if this line is raised. So if it's raised or if it's lowered, okay? So the ST segment being either raised or lowered can be indicative of heart damage, okay? Let's go back and take a look at that EKG.
Okay, so let's return to how we actually obtain an EKG. So what an EKG is, it's a view of the heart from a whole bunch of different angles, actually about 12 different angles. So think about it this way. If you have somebody approaching you with their hand behind their back, and they have a knife, they're holding a knife behind their back, you're only going to see their front, their anterior view. But if you go all the way around the patient and you look at them from the opposite direction, 180 degrees, you will see them holding a knife behind them. It's the same concept with 12 lead EKGs. We're taking a look at the heart from 12 different angles, and we're looking to see how the electricity flows through the heart muscle. Okay? So it's also important to note that the heart has different regions, and each of those regions has its own blood supply through the coronary arteries, as previously discussed. So in this slide, we see a green region, a yellow region, a light blue, and a purple region. So each of those regions is supplied, as I said, by certain coronary arteries. So for example, the RCA, the right coronary artery, supplies the green portion of the heart in the slide, and that actually is most of the right atrium and the right ventricle, versus the LAD, the left anterior descending, that supplies the front surface, so the anterior surface of the left ventricle. There are a couple other coronary arteries, but you get the feel of it. Okay. When we actually do the 12 lead, this is what we call Einthoven's triangle. And basically what it is it's a way of mapping out in which direction we're looking at the heart electrically. So it's all the different angles and all the numbers and the letters you see there. They're what we call the different leads, the different views. Like there's lead 1, lead 2, lead 3, Roman numerals. There's also AVR, AVL, AVF, and V1 through V6. Okay, those are the different leads. This is what an EKG looks like, and these are the actual 12 different views. So we see right. Where's my cursor? There it is. Okay, so here's lead 1, here's lead 2, here's lead 3. Here's AVR, AVL, AVF, and leads V1, V2, V3, V4, V5, V6. This is a 6-second strip down here at the bottom of lead 2. It's just the way monitors are set up. Okay, so those are the 12 leads. This is a normal EKG, and each of these leads, each of these views correlates, as we said, to a region of the heart. So if we're looking at leads 2, 3, and AVF, those correlate with, in our diagram, the green region, which is the inferior portion of the heart. So let's take a look at that in just a minute here, okay? Versus anterior-wise, you're looking at leads V1 through V6. So keep this in mind now. The green region, inferior, leads 2, 3, and AVF. Let's take a look. All right. The green region is fed by the right coronary artery. That means if we have an issue here in the green region, leads 2, 3, and AVF, the issue stems most probably from the right coronary artery, from an occlusion of the right coronary artery. Okay? So again, here is a normal EKG, and now we're going to take a look at what an abnormal EKG looks like. So here we see ST segment elevation in leads 2, 3, and AVF. So remember, 2, 3, and AVF point towards the green section of the heart, which in this case is the inferior portion of the heart, which, there we go, right there, which feeds the right ventricle, which is fed by the right coronary artery. To confirm this, it's like a seesaw. If one end of the seesaw is high, the other end is low. So we see ST segment elevation leads 2, 3, and AVF. We should see what's called reciprocal depression and at least one of the V leads. And here we go right here. There's ST segment depression in lead V2 here. Okay, so now what do we do with this guy? So as soon as this came out of the 12 lead EKG or heart monitor, my partner took a look at it. He recognized it immediately, took a look at me, handed it to me, and we told the gentleman, okay, what you're experiencing right now is what we suspect very strongly to be a heart attack, specifically of the right-hand side of your heart. So we immediately called dispatch. We had dispatch call a cath team alert, or what we call a Stemi alert. ST segment elevation MI. MI is myocardial infarction. So we had the dispatcher call the closest cath lab hospital and activate their cath lab team, because this was on a weekend and they're coming from home. So we need to get them to the cath lab very, very, very quickly, because their job is going to be to insert catheters into this gentleman, whether it's radial artery or femoral artery, to get back up into the heart and literally feed catheters up into the heart and inject dye to do what's called an angiogram to determine what vessel is blocked. Once they determine what vessel is blocked, there are numerous ways they can open it up. It's just like plumbing. Okay, you can either pour Drano down the drain if the drain is stopped up, or you can use a plunger, or you can use a snake. And it's basically the same thing. They can either give medicine to help break up that occlusion, or they can force their way through the occlusion. And this is what's called a balloon angioplasty. What they do is they insert a catheter through the occlusion, and then they deploy the balloon, and it squeezes that plaque into the walls of the coronary artery, and then they go and they put a stent in there, and that stent is basically a thing that keeps that artery open and becomes incorporated over the years, over time, into the coronary artery to keep it open. Okay, so we tell this guy what's going on, and we gave him 324 milligrams of aspirin, PO, orally, so 81 milligrams times 4 chewed, because that will help hopefully break apart the occlusion. And we immediately put an IV in one hand, and we put him on some oxygen to supplement him. And my partner put the AED pads on him, the defibrillator pads on him, not because he was in ventricular fibrillation, but because STEMI patients are at risk of deteriorating quickly into ventricular fibrillation. And I don't want to waste time in the back of the ambulance being alone, because my partner's up front, having to put the pads on. So we put the pads on, put him on a stretcher, got him into the ambulance. I called the hospital directly, again reiterated that we have a 66-year-old male STEMI alert, inferior wall MI, with an ETA of about 5 to 10 minutes. And I put a second IV in him. Whole time explaining to him what was going on, because this can be a very, very scary time, especially if it's his first heart attack. If it's your third or fourth heart attack, you're old hat at it, you know what I mean? But this was his first. We got him to the emergency department, and they transferred him to the cath lab. The team arrived very shortly thereafter, and now we'll take a look at the angiogram. There we go right here. So the top picture right here, it took 75 minutes from the time that we arrived at bedside at the patient's laying on a sofa to the time when they deployed that balloon and opened up his coronary artery. So here we have the pre and the post pictures. This is what it should look like. Here's his right coronary artery. Should be nice and, good blood flow. Here, we don't see that. So he has a proximal right coronary artery occlusion. And it actually was 100% occluded. It's pretty safe to say that if he had waited an additional 5 or 10 minutes to call 911, he might not have survived. It turns out he went through the cardiac catheterization and balloon angioplasty with stent deployment very well. And last I heard, he was post-op a few hours afterwards and doing very, very well. So there you have it, a 100% occlusion of the right coronary artery STEMI case.